Welcome to PsychCase360.
We're happy you've joined us. We're going to review 2 cases for you showing the challenges and effective treatments in schizophrenia. I'm Dr. Roueen Rafeyan, Clinical Assistant Professor of Psychiatry at Northwestern University, Feinberg School of Medicine. I'm delighted to have been joined by my colleague, Melissa Vitale from Reset Psychiatry.
Here is the first patient example that we're going to walk through. His name is José. He's a 29-year-old grocery store clerk living with schizophrenia for about 5 years now. He's been seen at our clinic since referral from his primary care provider 5 years ago. And he's struggled a lot with adherence to oral medications since he's been diagnosed, which we see a lot of struggles with oral adherence.
That is so common.
Yeah.
Actually, starting with this history, I think for those of us who treat schizophrenia, we see this on a daily basis. One of the challenges with this disorder is adhering to medication. And by the way, medication compliance, or what I usually like to refer to it as partial compliance,
Yes.
is not unique to schizophrenia. And we see this with all disease states, that it's just human nature. It's difficult to adhere to strict medication regimen.
And remember to take your meds if you're traveling or whatnot. So Jose here, he's experienced multiple relapses over the last few years due to a lot of these missed doses of medication, his oral medication, leading to repeated hospitalizations, which have then disrupted his work and family life due to his relapses.
Melissa, I think we are just being very general when talking about disruption to work and social life. But with each relapse, and you've had that experience as well, it's more than that. The impact of a relapse on a patient goes beyond.
Detrimental. Right. So despite understanding the importance of taking his meds, he's had difficulty maintaining the daily regimen, especially periods where his symptoms worsen, right? It's almost like a revolving door downhill type process when he stops taking his meds and then starts to relapse. Jose and his care team have decided that a long-acting injectable would be a good option for him, as it would increase the adherence and lower the risk of subsequent relapses or delay those times to those relapses. So really, when we're talking to our patients about a long-acting injection, it's always good to use positive interviewing, right? Ask the patient what their goals are. Are their goals to, maintain his job as a store clerk or, maintain those social relationships with his parents, or maybe he has a girlfriend, right? So we're going to use that when talking to him about, how beneficial an LAI might be for him.
Yeah. And, when you're just touching upon some of the challenges, there are a couple here that I would like to share with our audience as clinicians. We tend not to think about long-actings earlier in the course of the treatment. We wait till a patient like Jose has multiple hospitalizations before thinking maybe a long-acting is a good choice in his treatment. However, again, we talked about it earlier, each relapse, patients lose. There's a lot to lose with each relapse. Disease gets more difficult to treat. Potentially may even end up treatment resistance.
Mm-hmm.
When we have effective ways of delivering a medication, it should be considered early on in the treatment. And then many times patients will push back. Again, let's be real. They have concerns about getting an injection. At that point, we have to implement a lot of motivational interviewing, getting them to collaborate with us to accept an injectable. So.
Yes. And we also want to remind them that, LAIs aren't only for a last resort, right? So, make sure that they understand it's not the same as that immediate acting injection that they might have received in an inpatient setting or so on. So in this case, Jose has accepted to take a form of a long-acting injection, and he switched from his oral risperidone to risperidone subcutaneous once monthly injection.
Which, in this case, it makes sense. He is on risperidone. The treatment team has established that he responds to this compound. tolerates it fairly well. So a good move trying to switch him to an injectable form of oral risperidone.
Yes, yes. So Jose comes in at his next appointment and he reports to us some injection site pain and itching. And so we decide to then switch him to paliperidone palmitate once monthly. So we're going to refer to this as PPOM in the future when talking about paliperidone once monthly.
Yeah, that's a good example of good decision on initial injection as a long-acting. It's the same compound. However, for reasons that the patient is expressing, it's not comfortable getting a sub-Q injection. Otherwise, the injection choice was good. Could have really helped him in the long term. Now, we have to look at another compound that is close or same as risperidone, but it is not sub-Q. So it does, again, make sense that treatment team decided to go with paliperidone palmitate once monthly.
So he completes the 2 loading doses with ease, and he doesn't experience any injection site pain or itching. And then we schedule him for his next injection 30 days later. So Jose then, as time goes on, he continues to struggle with keeping his appointments, as we see quite often with our patients and follow-ups. And he misses his scheduled appointment and comes to the clinic 6 weeks following his last injection. At that time, we noticed some breakthrough symptoms, including paranoia and hallucinations. And we've also noticed some poor hygiene and so on. So at that point, he is tolerating the injections well. He's not having any injection site pain. The medication does work for him when he is adherent to the plan and timing.
You know, what you just covered so far is such a common problem. Many of the injections that are monthly, every 4 weeks. Again, our patients with the schizophrenia struggle with keeping appointments, coming on time. Very common. They will walk in 6 weeks, 7 weeks later. And then that leaves us in a difficult spot, because what do we do? Do we start all over again? So it is a common problem in clinical practice.
Yes, yes. And the current dose of 156 milligrams had been doing well, controlling his symptoms, but efficacy had then waned.
Since it was supposed to come in at 4 weeks, it shows up at 6 weeks. Well, medication levels do drop, and he's showing breakthrough symptoms.
Yes.
Now, at this point, the question is, what do we do? Do we increase the psychosocial interventions? Talk to the case managers, to his parents, or if there's anyone involved in his care, to make sure that he comes in every 4 weeks, because we need to make sure he gets the medication every 4 weeks. Because again, paliperidone palmitate comes in a 3-month and a 6-month version. So if we are thinking that he is a good candidate for that, but we still need to have him on paliperidone palmitate monthly for 4 months. So that's when we really have to get all the help we can to make sure he makes it to the...
And I think it's also important to let him know about those 3 and 6 month options. So it's something that he can work towards and set a goal to get to. So that's when we, would have that conversation with him of the need to maintain those appointments monthly for the next 2 to 3 months, so that we can have him on a steady dose and get him to steady state on the paliperidone palmitate and ensure efficacy at that time.
No, so you brought up a great point. To discuss with him early on that, look, we're considering this medication for you for the first 4 months. It's going to be once a month. However, once we establish that you're doing okay on it, you're tolerating it okay, it is controlling your symptoms adequately, then you have 2 options: to every 3 months or once every 6 months. And that becomes a point that many patients will understand and become more invested in their treatment, because it's much easier to get an injection once every 3 months or once every 6 months.
2 times a year.
Yeah. So
yes. And we also have to remind the patient that just because they're only on the once every 3 month or once every 6 month dosing schedule, we can still bring them into the office and see them and focus on other aspects of their life, like their social life, their work, maybe how their, medical care has been going. So
you're touching upon another important aspect. Many of colleagues and clinicians believe that if I go to the 3 month or the 6 month, I have to see the patient in 3 months, which is not true. Medication is given once every 3 months or 6 months. We still need to see the patients in intervals that we feel is appropriate according to their treatment plan. The only issue is that we're not going to spend a whole lot of time talking about medication and focus on other aspects.
Right.
But part of that regular visit, that maybe every 2 weeks, maybe every month, to make sure they're tolerating the medication, okay, there are no side effects, and then what else are they doing? What else needs to happen in their treatment to move them forward? So, if you look at some of the, we do a PubMed search and looking at the efficacy of oral medications versus injectables, really establishes that patients on injectables tend to do better. And it's a simple reason: the medication is in their system. It's
Very
exactly
simple.
very simple. The medication that works with them is actually delivered to them, rather than with pills we prescribe. We hope they take it. They sometimes take, sometimes don't. How much they take, we don't know. So
We have to do a lot of digging.
yeah. Again, further analysis of looking at efficacy of the long-acting versus oral medications, showing us that long-actings actually tend to have better outcomes. This was an interesting study. Was patients stabilized on paliperidone palmitate, then randomized to either continuing on paliperidone palmitate monthly or placebo. The outcome was time to relapse. And also, for our audience, it's important to know relapse in these studies is defined a little different. In our office, if a patient is agitated and psychotic and requires hospitalization, we consider that relapse.
Correct.
In these studies, for ethical reasons, any increase in PANSS score is a relapse. If a patient comes in one day and they're hearing more voices, that's a relapse. If a patient comes in one day, they're a little irritable, that's relapse. That's for ethical reasons, because we don't know who's on the medication, who's on placebo. For that reason, we have to yank them from the study and treat them conventionally. So with that low threshold of defining relapse, the patients who are on paliperidone palmitate show significantly less relapse in a long timeline. It's almost 300 days.
Only 15 of 156 subjects on paliperidone palmitate once monthly had suffered a relapse, which is pretty incredible compared to the 141 of 156 remained relapse-free. That's amazing. So now here we'll talk about some of the safety profiles of paliperidone palmitate, and these are things that we're going to be monitoring our patients for once we do put them on the injection. Some of the most common adverse events are injection site reactions, sedation, dizziness, akathisia. These are all things that, even if we have patients on orals, except for injection site reactions, are things that we're going to be monitoring for during our follow-up visits as well. Paliperidone also does have that prolactin elevating effect. I don't typically draw prolactin levels unless I see symptoms of prolactin elevation. What about you?
That is very common. Let's keep in mind that prolactin has a diurnal secretion. So depending what time of the day we draw the levels, it can be up and down. And there are no standards as of when do we consider prolactin elevation. So most of us, our approach is clinical. If the patient is showing any symptoms that could potentially be due to increased prolactin, then we check and monitor. For example, any changes in their menstrual cycle, any tenderness in their breast, any galacturia. Those are the main symptoms that I clinically monitor. And if I see that, then definitely check the prolactin levels and then
go from there and make some changes if needed. We're seeing Jose back in the clinic after he's been on paliperidone palmitate once monthly for 5 months now. He has been keeping his appointments, and he says he's doing so much better. He's been consistent with his work and resumed his social activities. And we note improvement in his hygiene. He's starting to look a lot better. He does have an issue, though. He says that he wants to go back home to see his grandma in Puerto Rico for her birthday, and he won't be able to make it back in time for his next injection. So this is where we had to sit down and discuss with him. He's been stable on PPOM monthly for 5 months now.
5 months now. So that is a good time actually to discuss the options. Because again, if we initially had talked to him about that, if we are doing okay on the monthly, we have the option of going to either the 3-month or the 6-month version of the same medication. And now there's a issue coming up that he's going to be traveling, won't be able to come back for his regular monthly follow-up injection. It's a great time to talk to him about, hey, the medication that you're on is available in a 3-month and a 6-month.
The exact same formulation. And, we can talk to him about how good he's been doing. The risk of him not making it back in time for that next injection, that could be a risk to, initiate a possible relapse as well. So to maintain his stability, it would be a great idea to go to the once every 3 months or once every 6 months. And this is kind of like a reminder to him, because we've also brought this up when he started the injections, and it was something like a goal to look forward to in the future.
Yeah. Now, here are some issues that we need to address. Sometimes patient caregivers will ask the question too, are you sure the medication is going to last 3 months? Are you sure the medication is going to last 6 months? So a lot of education goes into that to ensure that it's the same compound. Interval is different, but it's the same medication. And take precautions and educate them and reassure them that they will be okay.
Yeah, exactly.
So what you see here results from a 1-year non-inferiority study comparing the 6-month paliperidone palmitate to the 3 months. And as you see, the studies, when you do almost head-to-head trials, you never see a superiority. Usually they're designed based on non-inferiority, which means we take the 3 months, we were familiar with it, it's been around for a while, and then the 6-month version is available. Let's look to see if it works as good. And this is 1 year, and as you see, patients remain relapse-free at 1 year. So 96.1% of the patients receiving the 6-month version of the paliperidone palmitate remain relapse-free for 2 years.
Yeah, in the open label extension study. So that is pretty amazing. I mean, imagine 96.1% of your patients remaining relapse-free for 2 years.
And I always say, if for those of us who treat schizophrenia, if I can keep 96% of my patients stable for 2 years, I have done good.
Yes, you have. Yes, you have.
So what are the side effects? What did we see? Because again, we want to know, patients want to know. So what you see here are the side effects throughout the trials, various trials, with the 3-month paliperidone palmitate and also the 6-month paliperidone palmitate. Good number of patients. As you see, the N numbers are pretty good number of patients. So we see about 12-13% upper respiratory tract infection, about 5%, 11% injection site reaction. Weight increases about 8-9%, headaches 5-7%, EPS 5-7%, akathisia 4%, and the numbers drop down.
I mean, what we see is really that no new safety signals emerged between the 3-month and the 6 months. So the side effects are very comparable to each other as well. And we want to make sure of that as well, because now we're deciding to put our patient on, an every 6-month injection. Yeah,
it is important to really know this data. Because again, once we give an injection, we can take it out. So let's make sure that we know what to expect.
Exactly. So how is Jose doing now, right? After we have started him on, we ended up choosing to go with the once every 6-month paliperidone palmitate, right? Because he's doing so well on his once monthly, we then decided to go with the 6-month dose. He says that it was great to catch up with his family and old friends. He was super grateful to be able to attend his grandma's birthday and not have to change his flights to come back home early for his injection. His work is improving, and he's been at that point consistently keeping his appointments. We ended up bringing him in at least quarterly. That's the max we'll push out between injections, even though despite he's on that once every 6-month dosing.
I completely agree. So, I mean, it's a good example of how having him on medication, stable medication, will keep him stable, and we can see him as frequently as we need to.
Exactly. Now we're moving on to Sarah. She's the next patient we're going to be reviewing. And Sarah is a 21-year-old college student who was recently diagnosed with schizophrenia 6 months ago after experiencing her second psychotic episode while she was home from school on summer break. She was started on oral risperidone after her diagnosis, and she did demonstrate clinical improvement and stability, and she did tolerate the medication well for a while. What we see very often is she ended up going back to school and she stopped the medication due to the stigma that she felt after her roommate had found her medication and then Googled and found out what it was for. So she had a ton of self-stigma, and she internalized those prejudices that others, had about her externally. She also had some issues with weight gain. She had gained 4 pounds, and Sarah is really big into exercise and diet, and so this was really frustrating for her. So she decided just to dump her meds in the toilet. Of course, when our patients stop taking their oral medications, we often then will see relapse and symptoms of relapse, and she ended up being rehospitalized, where she was restarted on her oral risperidone, and then of course counseled to maintain adherence with that. And we do see that a lot. Our patients are hospitalized due to a relapse, and then a lot of times they're actually restarted on that same oral medication that they were supposed to be on coming in. And the main thing I feel for that is because they weren't taking it to begin with, right?
Yeah. So, great case example of a new onset disease. As you all know, for the first 6 months, if someone is showing psychotic symptoms, it is still schizophreniform disorder. If it lasts past 6 months, then we get the diagnosis of schizophrenia. In my opinion, these are the crucial times to implement effective treatments, because patients have a lot to lose again at this juncture. And going back to our patient, Sarah, started college. My main treatment goal would be to keep her in college.
Yes.
If she keeps having relapses, that's not going to happen. So we have to keep her. Like any other college student, she's going to be female, college, going to be sensitive to weight gain. We have to be sensitive about that. Stigma is another one that is going to take a lot of work with her parents regarding the diagnosis, acceptance of the diagnosis, to ensure effective treatments and treatment compliance.
Medication, because a lot of patients will start feeling better and then they'll stop their medication and not really believe that they have the diagnosis. Yeah. So here, Sarah, we see her at our clinic 12 days post-discharge of her second hospitalization.
Let me just talk a little bit about what I meant when I said there are consequences to relapse and diagnostic. When a patient exhibits psychotic symptoms for the first time, we need routine labs. Imaging is important. The main reason is we want to make sure there are no other lesions in the brain that could potentially cause psychotic symptoms. It could be a tumor, it could be an arteriovenous malformation, it could be a cyst, it could be many other things. So that's why imaging is preferred. At least a CT scan, if you can get an MRI, shows you the brain better. By the way, when you do these imagings, many times it comes out okay. There are no other lesions there. However, data shows us that patients with schizophrenia tend to have enlarged lateral ventricles.
Very interesting.
So if I see that, along with the symptoms that has been there for more than 6 months, more likely for me to feel more comfortable going with the diagnosis of schizophrenia. What else do I need to rule out? Urine toxicology. It has to be there. Usually when we order a urine toxicologist, the 9 panel that shows us any of these compounds that you see here on this slide.
But now we have these designer drugs.
And designers, we have to actually be specific. For example, K2 and spice, which are the synthetic cannabis, they are full agonist. As a result, the effect is more like a psychosis rather than the high that is achieved with
regular
cancer. So that requires a specification to get that. Kratom is another drug that is widely used everywhere. It can potentiate, and many other drugs that are just being utilized these days. So some of that requires clinicians to stay on top of what is the newest fad of drug that is circulating in our community.
And really take a deep dive into our patients and ask them, what they have been taking.
What else do we want to know? Regular routine labs, CBC. We want to take a look at that to see if there's anything abnormal there, followed by their lipid profile. And we need to just regularly call it the CMP to know how their liver is working, how their kidneys are functioning. Because again, that plays a role in what meds we're going to give them, or if there are issues there anywhere, and will also allow us to monitor them for any metabolic issues moving forward. And one of the best indicators of potential for metabolic issues are the triglycerides. So I really encourage all colleagues to pay attention to triglycerides. So going back to our case, we do the clinical interview. We go over the symptomatology, duration of the symptoms. Again, positive symptoms, negative symptoms. We're looking at all of these as of as I say in PANS, general psychopathology symptoms. We want to know all about that. We want to establish her baseline functioning, what her interests are, and what are the concerns with the previous medication, and why did she stop taking the risperidone, as we discussed. And then, in her case, again, young female, I would check her prolactin level, especially if she was showing some symptoms associated with increased prolactin.
She notes that she's having some disruption in her menstrual cycle. She also notes galactorrhea, and she's also still concerned about the weight gain and sedation. So we really now are thinking, okay, she's already stopped this medication once due to side effects. Maybe this is not the medication for her, for this specific patient, right? She's in college. We want to keep her sharp. So we might want to think about a medication that might not have as much cognitive dysfunction or cause any hinder on that cognition. And definitely avoid any medications are potent for histamine or histaminergic activity, so that she's able to stay alert and complete her coursework. Because like Dr. Rafeyan said earlier, our goal is to really keep her in school.
Yeah, because we need to preserve functioning. And we know cognition is affected with this disease, even before the start of the disease. We don't have any pro-cognitive medications to prescribe our patients. So my approach is, let's at least avoid worsening the cognitive problems. One way of avoiding that is not to use medications that are very histaminic. Antihistaminic properties will have an impact on cognition.
Mm-hmm. So in the case of Sarah, we would likely draw a prolactin level, just to see how high it is and make sure that she does have issues with high prolactin levels, and that's what we would probably typically see. And here we see that her prolactin level does come back at 146.4. So we're going to think about then, what can we switch Sarah to, considering her goals and her preferences on something that's not going to interfere with her cognition, something that's not going to significantly cause fatigue, and something that is not going to be increasing her prolactin levels, right? So we're going to explore here 3 options and kind of like our thought process of what meds are we going to consider for her. One of the 3 options would be xanomeline trospium, which is one of our newer, it's a novel combination medicine, M1, M4 agonist with a peripheral muscarinic antagonist attached to it. Another medication we're going to think about that would fit what Sarah is desiring is cariprazine, which is a partial D2 and D3 receptor agonist, and also serotonin 5-HT1A. We have to remember that she has had issues with adherence to orals, right? So the xanomeline trospium, that does need to be taken twice a day. Cariprazine does need to be taken daily. These are both oral medications. So we do have to think about a possible LAI option for Sarah to decrease or lengthen her time to relapse.
So we're trying to choose from potential options, from all the options we have. What is she sensitive to? What are we trying to avoid? And what are we trying to achieve? We don't want her sedated.
Mm-hmm.
We want to preserve her cognition as much as possible. She's complaining about weight, so potentially choosing an option that is not going to cause weight gain.
Or a lower propensity to.
I like the way you put it. Exactly. So that narrows us down to a limited number of available options. Another one that needs to be taken into consideration, she's having symptoms due to increased prolactin. So we have to consider medication that actually doesn't increase prolactin and hopefully potentially can help reduce this already elevated prolactin levels, which really limits it to the partial agonist. Among partial agonists, the only one that is available in the long-acting is aripiprazole.
So these are the three medications, and we'll go over our thought process of how we're going to choose which medication that would be most suitable for Sarah.
So one medication that is available, is actually the newest one available to us with a novel mechanism of action, is the xanomeline trospium. It's a combo medication, which has been shown in short-term and long-term trials to have significant efficacy against positive symptoms, negative symptoms, and general psychopathology. So this becomes a good choice for a patient like Sarah, especially when we look at side effect profile. Again, we don't see the akathisia, we don't see the EPS. Weight actually stays fairly neutral on this medication. However, it's associated with some GI side effects. It is a BID dosing. Again, it's an oral medication. Mm-hmm. So we're talking about a college student that needs to remain adherent to a BID medication when she already was struggling with the first oral medication. So
and also self-stigma, right? So one of her main concerns would be to bring another medication in a bottle back into her dorm room.
Yeah. And having to explain that to friends and roommates as to why I am on this medication. So another medication that we may consider is that partial agonist should be considered here for her is cariprazine. Again, looking at the data for cariprazine, 3 milligrams, 6 milligram, we see this effective in reducing total PANSS scores in their initial registry trials. It works, has the indication for schizophrenia. Actually, here on this study, you also see the 10 milligram aripiprazole. Because we are thinking about, again, if we're thinking about long-acting, aripiprazole, another option as a long-acting. So
these are pretty comparable in the decrease in PANSS scores.
Side effects. What do we see with weight? Data from cariprazine studies. It seems like there is mean change of about 2 pounds, about 8% of the patients. EPS rates were about 15% versus 8% placebo. Akathisia rates 9% at 1.5 to 3 milligram. The second studied 19 to 13 milligram. As we go a little further up in the different studies, numbers come up a little bit different. So we see EPS, we see akathisia. There's a little weight, but prolactin levels don't go up on this compound, and not a whole lot of impact on the metabolics.
Right, it's pretty metabolically friendly. But we also have to remember, again, this is an oral medication.
Oral medication.
So now we move on to the aripiprazole once monthly.
So, here now we've really narrowed down our choices to this patient will benefit from a long-acting injectable. What do we know about aripiprazole? Again, we've had clinical experience with aripiprazole since 2002. So number of years of experience with this compound. We know the efficacy of the oral medication, side effects of it. How about the monthly injection? The data shows us it's actually effective against positive and negative symptoms. Generally, this is total PANSS scores in one of the early trials that shows significant 27-point reduction in PANSS, which is quite impressive. CGI, which is clinician's global impression, is our eyes looking at the patient, not just the numbers and scales. 1.5 point reduction in CGI, which actually is quite significant. So there is data. We have quite a bit of data about efficacy of this monthly injection. Side effects, again, familiar. You see, actually look for the once or twice more than the placebo. Dry mouth at 4%, diarrhea 3% versus placebo 2%. Average weight gain on 400 milligram was 3.5 kilograms. Placebo was 0.8. Number of patients gaining weight more than 7% was about 21%, about 31 out of 144. Mean change from baseline to week 12 with the prolactin was a minus number. The glucose levels really didn't change that much. So as the clinicians, we have to weigh our options.
Right, the risk versus the benefit.
Yeah. So what's the benefit? We can have the effective medication in her system, keep her symptoms stable, help her graduate college, which is the real goal. May come at a little cost of a little weight.
Decrease prolactin.
But the prolactin will go down. And metabolically, we know we have a lot of experience with this compound. It doesn't have a whole lot of impact on the metabolics. So,
and her metabolics, as we reviewed to start, are pretty good.
Pretty good to start. She's young, so far so good.
And we can always monitor this, but this will hopefully keep her stable for longer. So we start Sarah on the once monthly aripiprazole, and she's open to doing that. And she comes back and sees us in the clinic for her next dose. She notes that her symptoms are well controlled. She's no longer feeling fatigued and sedated during school. She's able to complete a lot of her projects. Her prolactin levels have now normalized. So we do repeat those as time goes on, just to see to make sure that they are going down with the aripiprazole. And her galactorrhea has also resolved. We are, however, monitoring her weight because, as we know, there is a chance that she can still gain weight with the LAI aripiprazole. So we are monitoring that. She hasn't gained any additional weight from where she was prior to starting. So we're now going to talk about possibly moving her to the every 2-month formulation of aripiprazole in time. We do want to let her know that that is an option for her as long as she maintains and does well with the once monthly dosing.
So a very appropriate way of approaching this case. And our goal was to really go through a clinician's eye based on the patient presentations, factors that influence our decision-making, and how do we end up choosing which medication for which patient. Was a very real-life patients that we wanted to discuss with our audience. Hopefully this was beneficial for you.
Thank you so much.